गुड इवनिंग पंकज भाई।
गौरंग भाई, मैं थोड़ा 15-20 मिनट लेट ज्वाइन करूंगा।
हाँ, ओके ओके,
आप
बट
शुरू
प्लीज
कीजिए,
ज्वाइन।
मैं करीब 9:20 तक वापस ज्वाइन करता हूँ।
श्योर, बिकॉज टुडे इज द लास्ट डे एंड इट इज अ मोस्ट इंटरेस्टिंग टॉपिक फॉर यू आल्सो।
श्योरली श्योरली।
हाँ, ओके।
चलो, ओके। सो मैं जितनी देर कर सकता हूँ अभी करता हूँ। मेरे को एक 15 मिनट बीच में ड्राइव करना है।
श्योर श्योर, ओके।
ओके या।
Rahul, who is answering today?
Sir, Dr. Ankit, Dr. Samit, and Dr. Brijesh are answering today.
Ankit,
Dr.
Samit,
Samit and
and
Dr. Brijesh.
Vijay. Okay. So the final finale will be with these three, huh?
Yes, sir.
Stalwart. The three who have always been there answering in our Zoom meeting.
Yes, sir.
Yes. We wait for 5 minutes. Okay, let uh, Dr. Gite and all join and then we start. Huh?
Yes, sir.
So, Samit, before we start,
Yes, sir.
you have been answering most of the time. So, can you just spare some time to give your views, what you think, and what extra we can do so that
Sir,
the other all the students are will be benefited.
so these classes are actually amazing. It's a way of good practice before the final exams. And actually, it's like once you attend, initially I used to be afraid that what like I will answer and what would be the opinions and how the other faculties will judge on me and all. But sir, over a period of time, once you keep answering and once you keep attending, you get that confidence in it, so that you feel like you need to answer more, and so that will eventually help for exams. And this is a good platform here that you can make all the mistakes, so that everything is rectified, and in the exam you are simply perfect, and you just have a good time with the examiners there.
Ankit,
Yes, sir.
what is your message?
Sir, initially we had मतलब हम लोग का सब theory, we were prepared for the theory, but we were not aware, being a DNB resident, we were not aware how the practical would go around. So this class has proven to be very confidence building to us. We can now give, we now know all how the question will be asked and what area we have to cover and where we are lacking. And this has been a great platform to for self confidence building for me at least.
So, do you have any suggestion? Anything like you feel we are missing something add, or we can add something to our classes because this is a last, and then we will have a practical classes. That's why.
Basically, we all the class, all the topics has been covered in detail. But like some small classes like on the hypospadias and that descendant
Yes, sir.
testes, these those short cases which are being kept, so these I feel, and histopathology section that we are not well versed with. Most of who are attending these classes are from DNB Institute, so we don't have the histopathology section like. So and these are kept in the exam, so we are not that well versed with these things. This may be taken care of, and the rest of the things are all already loaded in the videos, like the instrument and mock examination board on that has already been uploaded, that has already been covered. So I think these things should be, matlab, agar if it can be added after the theory examination, that will be of great help to us.
Fine, fine. In two classes we had taken that pathology also, but what you are saying is right. Now we will have one radio Euro meet also, like radiology and DTPS scans, sonography,
Yes, sir.
other things during after your DNB exam. So
Sir,
after
Yes,
theory is
sir.
over,
sir,
na?
once the theory is over, na, sir, we can do our OSCE slides also. We had, because during COVID we had made it, no, sir.
Correct, correct.
So that
So,
we with the pathology, radiology, everything will get covered. So
right, right.
we'll open that program again, and maybe we'll work on it once the theory is over.
Okay, so now the only Brijesh, what is your view? Brijesh? Samit, you can hear me?
Yes, yes, we can hear you.
Okay, okay. I think then we start it now. Who, Doctor Dr. Gite has joined.
Sir, am I audible?
Yeah, Brijesh.
Yeah. Sir, first of all, I would like to thank each and every faculty, sir, starting with you, Dr. Hiren Sodha, sir, Pankaj, sir, Gite, sir, and all the respected faculties which have helped each and every student since many times, sir. Like from many years of the starting of this program, I have not seen such a beautiful urological interaction program. Like we always face difficulty in exam, and in knowing these cases we have multiple times we have faced difficulties, and each and every urological resident has gone through the same process, which things to ask, which things to speak in the exam. So what are the fallacies, what needs to be spoken, what needs to be attended, which areas needs to be focused everywhere. I think, sir, you are like I don't have any words to express, but I believe each and every student will be having the same feeling for each and every faculty, sir, because you have guided each and every student to go through this entire process. And this process of learning has not made us feel that it is difficult. It is like a daily ritual that has made each and everyone to go through this very easily. And we have seen every student's response in the group. I think it is a wonderful thing, sir. I'm very heartily indebted to all the teachers, sir. Hello?
Thank you very much. But I will suggest all of you that after this class is over, you can write down your views and can suggestion so that after the DNB theory exams are over, because MCS will be in November, so we'll have the mock exam in between, and before that we may have couple of classes to cover all the practical things and short cases. So just give your suggestion that what are the things you people need. So I'll prepare that and we will have it. So I think Rahul, can we start now?
Yes, sir. 50-year-old male patient presented with complaints of urgency, frequency, nocturia, and poor stream since last 6 months, dysuria and burning micturition for last 3 months, urinary retention, multiple episodes in the last 2 months. Patient has perurethral catheter in situ at present on presentation.
Okay, Brijesh, you can elaborate. What are the question you want to ask?
Sir, I would like to elaborate the history of, sir, lower urinary tract symptoms. Sir, I would like to ask a detailed examination of storage symptoms and voiding symptoms, sir. Also, I would like to elaborate the history of dysuria, burning micturition, whether the symptoms have increased from the past, sir. On the history of urinary retention, sir, I would like to ask whether he was underwent any intervention for the retention, whether catheterized, if at the time of catheter, how much ml of the urine was there, sir, whether any other instrumentation or other procedure has been done. Also, I would like to elaborate the history of any, whether there is any history of hematuria, lithuria, pyuria, any lower urinary symptoms other than this, any constitutional symptoms, any back pain, bony pain, any history of any medical ailments, personal history, and also I would like to elaborate the history of diabetes, hypertension, and any tubercular history, sir.
He has covered almost anything. Samit, you want to ask? Apart from that, any point is left behind?
Uh, no, sir. In between, whether like he had retention in the last 2 months, so whether trial without catheter was given or not, or it was the first time he was catheterized. So more details about that.
Okay, fine. So those details were, I don't think it was available. And Ankit, you want to ask anything else?
Along with that, PSS scoring also we mentioned, sir. That's
Yes,
it.
yes,
Things have been covered.
yes. Sexual, whether
Yes, sir.
he is
Patient is
sexually
sexually
active
active
or
or not.
not, and yeah. And when you are asking these two things, apart from that, quality of life. So that is also very important. So never forget about these three things whenever you are asking about LUTs. Okay, Rahul, go ahead.
The patient was relatively asymptomatic 6 months ago when he started developing urgency, which was occasionally initial and now has progressed to be present before every void. Increased daytime frequency initially 3 to 4 hourly, now progressed to half hourly. Nocturia 1 to 2 per night initially, which has increased progressively to 5 to 6 times per night. Poor flow, noticed 6 months ago, and the flow has progressively decreased since then, associated with every void. It is also associated with straining during micturition, with no history of assisted bladder emptying. It was also associated with dysuria and burning micturition. Started 3 months back and progressed to be associated with every void throughout the stream. Patient also has history of acute urinary retention 2 months back, and he was catheterized then with failed trial without catheter twice. All the episodes were associated with sudden onset lower abdominal pain with inability to pass urine. No details are available regarding the amount and nature of output post catheterization. Currently, the patient has periurethral catheter in situ, last changed 5 days back. There is no history of intermittency, incontinence, hesitancy, hematuria, lithuria, pyuria, fever, abdominal pain, nausea, vomiting, local or abdominal trauma, loin swelling, or any constitutional symptoms, renal stones or metabolic disorders, jaundice, facial puffiness, exertional breathlessness, backache, or radiation or chemotherapy.
So only one history which is there was not really that was that patient guide wire first time over the guide wire there was some difficulty, some bleeding was there, and over the guide wire he was catheterized for the first time. But apart from them, this is a history. Okay, Rahul, go ahead.
Yes, sir. Patient had history of adrenal tuberculosis diagnosed 10 to 12 years back. AKT was initiated but discontinued by the patient within a month. It was followed by an episode of adrenal crisis which was medically managed. Since then, he is on tablet Vizol on 5 mg once a day and tablet Floricort 100 micrograms once a day. Patient has poor compliance with the medications and no reports are available to review. He has a history of hypertension on tablet amlodipine 5 milligram, no, known case of asthma and psoriasis, but not on any treatment. He has a history of cystoscopy 2 to 3 months back for his urinary complaints, which revealed low capacity drugs. He is allergic to sulfa drugs. Family history non-contributory. Personal history, bladder and sleep are disturbed as described. He is a non-smoker, non-alcoholic, non-tobacco chewer.
Hello.
Yes, sir.
Yes, sir.
Yeah. So Ankit, now this is a history. Now what you want to do?
Now I want to examine the patient, sir. Physical, general examination along with systemic and DRE, sir.
Okay, fine. Give the findings.
On general examination, patient is thin built, afebrile, vitally he was stable, external genitalia was normal, uncircumcised. On inspection, flat abdomen, generally normal, sir. Hernial sites were clear. Similarly, on palpation, normal temperature, non-tender abdomen, no obvious palpable lump, hernial orifices were normal, genital uncircumcised. Scrotum was normal, testis and penis were no significant findings. Sir. Percussion and auscultation were also normal. Even per rectal examination was prostate was not enlarged, firm in consistency, smooth surface, non-tender, no nodularity or induration, sir.
Samit, now just tell me, can you just summarize the case and tell us what are the positive findings?
Sir, a 50-year-old male patient with predominant had history of storage lower urinary tract symptoms and multiple episodes of retention in the past 2 months, for which he was catheterized with failed trial without catheter, and he was known hypertensive and on medication, and he had past history of adrenal TB, for which he was non-compliant with the medications. And post that he developed adrenal crisis, for which he's on Visolon and fludrocortisone tablet. And on examination wise, he was just thin built, rest everything was normal.
So what is your probable diagnosis?
So probable diagnosis, considering the positive history with predominant, and he underwent cystoscopy also in the past that suggested a low capacity bladder. So for which he might be, he was catheterized, and he was having failed trial without catheter attempts. So it could suspect that first differential would be. Sir, genitourinary Cox, as he had history of adrenal TB in the past, and with symptoms predominantly were also lower urinary tract symptoms, which were storage symptoms with retentions.
Just tell me, what are the different things you get in genitourinary Cox? Different organs and how they are affected.
So first is involvement of the there is hematogenous spread. There is a usually for history of pulmonary Cox is present, where there is hematogenous spread to the primary landing organs. Either it could be the kidney or globus minor of the epididymis. And involvement of the kidney starts from the cortex. It invades the medulla, reaching after the glomeruli reaching the medulla, entering the PCS, and then dissemination down via the ureter, and involvement of the ureter, followed by the bladder involvement. And also there is involvement of the internal and external genital organs, involving the testis, vas, prostate, seminal vesicles, along with very rare involvement of the urethra and penis, sir.
So Ankit,
Yes, sir.
so when you are examining the patients, okay,
Yes, sir.
what are the important things you will look for when you are suspecting genitourinary Cox?
Starting from general examination, I would like to see patient's build, his BMI, and any evidence of malnutrition like anemia, and whether there is any pedal edema, sign of CKD, pedal edema, shortness of breath, puffness of the face. And then coming on the on the exam systemic examination, we would be looking for any flank mass or flank tenderness, to look for any hydronephrotic kidney. And then coming on to the rectal
No.
examination.
What do you mean by hydronephrotic kidney in examination?
Any enlarged kidney, if there is any flank mass or there is any flank tenderness
Okay.
is there or not, whether we can feel the kidney or not.
Okay.
And on coming on to the digital rectal examination, first I would like to do the external genitalia examination, whether there is any sinus or fistula over the perineum or over the scrotal region. But I would like to feel the testis for its consistency and the epidermis for its bulkiness or any beaded appearance. And we would like to feel the vas for any beaded appearance or gritty appearances, gritty feeling. And on DRE, I would like to feel the prostate for any nodularity or any enlargement of the prostate or any bogginess in the prostate, sir.
Good. Very good. Okay. So this is a thing. Brijesh, now what you want to do?
Sir, I would like to investigate the patient, sir. I would like to do a urine routine. Then I would like to send 3 urine samples for acid-fast bacilli. I would like to do a urine culture, sir. With that, I would like to do a CBC, RFT, LFT, electrolytes, CRP, ESR, and as his age is 50, so I would also like to do a serum PSA. With that, I would like to do ultrasonography abdomen and abdomen pelvis as a clinical extension of my knowledge.
And also, sir, since the patient is having storage lets, I would like to have a bladder diary for 3 days along with Euroflow PVR, sir.
But he's on catheter.
Sorry. He's on catheter, sir.
Sir, a chest X-ray also.
And chest X-ray and X-ray KUB, sir.
Okay.
Yeah. Now today it's happening. Otherwise, it was so frustrating, It would happen only.
Rahul, show them all the investigation, what they were asked.
So these were the blood investigations, and CRP was elevated 40.6, ESR 22, while rest of the renal investigations were normal. Total leukocyte count was of 8,670 with 10% lymphocytes. This was the urine routine, and pus cells were innumerable. Red blood cells were 20 to 25 for high power feed, and the rest blood test was positive in the chemical examination. Rest it was normal.
Go ahead. Show them other investigations.
So this was the urine culture report which we had sent when the patient was admitted, and it was organism was Morganella morgani was isolated from its culture.
Amit, do you
Yes, sir.
see usually this type of infection?
No, sir.
So what is your interpretation?
Sir, this catheter might be from long, then might be there are certain or the specimen like it's not taken properly or contaminated. It could be because he's on catheter, so we were expecting, but the this organism is unlikely to be.
Ankit, what is your view?
This is a catheter-associated UTI, sir. It is a complicated UTI. And, it is a it is a hospital-acquired infection. Because of the POC, Morganella morgagni is most commonly associated with improper insertion of the police catheter. That's it, sir.
Yes. So Ankit, what
Yes,
you are
sir.
saying is right. It is a complicated urinary tract infection. Earlier, I also used to, once before reading, I also used to think the same way. Okay, this is something, wrong report or, falsely collected urine. But this is a very serious thing. That
Yes, sir.
patient has got a complicated urinary tract infection, long-standing catheterization, and many a times it becomes resistant to most of the drugs. So we have to be very careful.
Yes.
Right. Okay. What else you have asked?
Urine for
Ultrasonography.
AFB and ultrasonography.
Urine for AFB or gene expert?
Not detected.
Negative, sir.
So Samit, gene
Yes.
expert, where you will ask for a gene expert? What are the tissue or what? Where? Which are the fluids? Can you ask for the blood?
So sputum, not for blood, sir. Urine, sputum.
Why not for blood?
So blood usually. Uh, mm,
Ankit, you have any
the
answer?
the shedding of the mycobacterium is not seen only in case of like blood is positive in case of severe disseminated. So don't know, but maybe
No, the
blood is
reason
not
is that because the concentration is very poor in but
very poor.
there are very
Yes,
few bacteria you will see
Shedding
in
is
the
low.
blood
Yes, sir.
because the large amount,
Yes.
So then it becomes very difficult to diagnose. So that is why.
Yes.
Okay. But in a fluid, any other fluid where you are suspecting tuberculosis, gene expert can be sent.
Yes.
Fine. Go ahead.
So we have other records which were relevant to the examination, but they were done before the patient was catheterized. So we have a uroflowmetry of the patient, where
So
we have
as I
void
told
of.
you, this patient had come and before that only, this was a uroflowmetry. He had already done it by, before other investigations and when he came with the retention. Again, I had given you the history that on the guide wire, the first catheterization was done. So after that, subsequent catheterization was not a difficult one. So now this is a uroflowmetry.
So this was the RGMCU of the patient which he had brought.
Ankit, can you read it?
Yes, this is a new film. Sorry, sir. This is the MCU film showing the bladder is trabeculated with uh, mostly the neck of the bladder neck is not properly opening, and the position and it is not well positioned.
Mm.
It's not well positioned, and the contrast. There is anterior urethra appears to be normal, while there is mid in the prostatomembranous junction. There is short segment stricture appreciated, sir.
Okay. Show ultrasonography, Rahul.
So moderate narrowing in the proximal penile urethra and bulbar urethra, membranous and prostatic urethra are normal. No significant post-word residue was seen. This was 2 to 3 months ago, sir.
Samit.
Yes. So this is an ultrasonography of KUB, where starting from the side of the can't see the side. Uh, so the one of the kidney appears to be there is a moderate hydronephrosis, which is seen with dilatation of calais without any hyperechoic focus seen, and the other kidney appears to be normal with normal corticomedullary differentiation without any dilatation, and the the bladder appears to be well like adequately distended, and normal without any evidence of catheter in situ or any debris, and the prostate also appears to be normal without any uh, intravesical prostatic protrusions.
The left kidney, what you are feeling?
So there is a hydronephrosis there. There is dilatation of the
Hydrocalcicosis is there, sir, without any,
hydrocalicosis of the calyces.
So how you
without any.
differentiate between the cyst and the hydrocalyx?
Calyxes will be communicating with with
Communicating.
each and another, whereas the cyst will be will be separated and will not be communicating with the collecting system, sir.
Any other finding? Means any other way to differentiate between cyst and hydrocalyx?
Mm.
Okay. See, many a times now you will get even the dilated pelvis, or maybe there may be some dilated ureter also if there is a either a stricture or stone in the ureter. So not always, but many a times, most of the times it is associated with the dilated pelvis also. Second thing, you will be in the cyst, you can see that it is very well circumcised and it is away from the there are calyx you will be able to see. All the calyx will not be dilated in that.
Mm.
Okay, show the report.
Right kidney is normal in size and shape. The parenchyma shows normal echogenicity with maintained corticomedullary differentiation. A lower polar simple cyst is there. Left kidney cortex is replaced by presence of several cystic lesions, few of which demonstrate septations and organized echoes. No internal vascularity could be noted. Coarse calcifications are identified in the medulla in the lower polar region. CM differentiation is not appreciated. No perinephric free fluid. No evidence of transfixed tenderness. Favored represents secondary to a chronic infective or inflammatory etiology. Urinary bladder is adequately distended at a volume of 178 cc. The wall shows diffuse thickening and 0.5 centimeter with mild irregularity of its mucosal surface. Evidence of moderate to high grade mobile internal echoes as well as dependent debris. Bilateral VUJ appears slightly dilated. Prostate is not enlarged. The engrams normal.
He's not on catheter right now.
Nah, this was done before he was catheterized. Like 5 days before the presentation, he was catheterized outside, and the
Okay.
sonography was done around 15 days before that.
Okay.
Fine. So now next what you want to do?
The creatinine is normal. Would like to
CT,
go
I would
for a CT urography, sir, with delayed phase.
Why you want to do CT urography? Huh, Ankit? You know that this patient has got tuberculosis in past, not taken the treatment. Cystoscopy is showing small capacity bladder.
So I
Already.
would like to, first of all, it will stage the disease
So anyway,
along with.
first, okay, Ankit. First, now whatever history and whatever small investigations you have seen, what is the probable diagnosis, total diagnosis that is in your mind?
Most probably, sir, it is going to be a GUTV with the involvement of the left kidney, sir. Most probably non-functioning, but I can't comment whether it is functioning or not till I get a functional scan along with the anatomical scan, sir.
No, but what are the other investigations you have seen?
Sir, ESR is raised, sir, but the along with history, there is a history of adrenal TB along with the in low cap on cystoscopy there is low capacity bladder, sir. But ultrasound is the film in the ultrasound is not showing like that, sir. It is discordant with the finding in the with this.
And what about the uroflowmetry and
Euroflowmetry is suggestive of stricture disease along with MCU.
so
MCU.
that you have forgotten? So can you start from urethra to kidney? Can you tell me what are the findings?
Sir, in the urethra, sir, there is the narrowing seen in the proximal penile along with the bulbar urethra, and with the trabeculated bladder seen on the MCU film. And in the kidney, sir, there is the left kidney is left kidney is replaced by multiple cystic lesions with loss of corticomedullary differentiation, and there was no appreciable parenchyma which was visualized on the ultrasonography. And there was a right lower polar parapelvic cyst was noted.
Okay. So now you want a CT scan?
Yes.
Gaurang, can I come in?
Yes, yes, please.
Doctor, on what basis are you saying that this is genitourinary tuberculosis? Tell me one finding where genitourinary tuberculosis has been positive in this particular patient,
So till
except
now,
your past history of adrenal TB. What else is positive?
until now, we haven't got any finding which like any no major criteria have been fulfilled till now, and
Exactly. Then
we are
why
just
are you saying that this is a genitourinary tuberculosis patient?
sir, based on the history of the patient and based on the past history of the patient, along with the
Can you are you justified that based on past history you can diagnose somebody on
no sir,
as genitourinary tuberculosis?
no, we
No.
have to have evidence, sir,
You
of
have to have some
genitourinary.
evidence, isn't it?
Yes, sir.
So what
You
are
know,
you
you
doing
asked
for
for
that?
CT.
What are you doing for that? What
Sir,
isn't your aim should be to diagnose, no?
yes,
To
sir.
confirm the diagnosis. What are you doing for that?
Sir, first of all, sir,
You know, you asked
radiologically,
for a CT. You asked for a CT, and then you stopped because sir asked you why you want CT. You
sir,
could
we
have
want to
justified it.
stage and to see
You could.
to stage the disease and to see the sequelae of the
What
disease
is the
and
stage?
to
What
That
you
is what
have
I'm
not,
saying. Now, when sir was
doctor,
asking you why you want CT, you should have justified it why you want CT.
but doctor, you
Radiological
have not
evidence of.
radiologically you want to have evidence, but before that, laboratory wise, have you done any investigation for diagnosing genital
yes, sir.
tuberculosis?
Sir, gene expert was done and urine TB culture was done, which was negative
So
for
gene expert was negative, isn't it?
yes, yes, sir.
What is the sensitivity of gene expert?
Sir, it is gene expert 85 to 90%, sir.
85 to 90%. Now, if it is negative, 90% is a very high sensitivity or very low sensitivity?
High sensitivity.
High sensitivity. And in spite of such high sensitivity, your test is negative.
Yes, sir.
So, what else further you would focus on to get further test which will try and prove that it is a genitourinary tuberculosis?
The tissue
Sir, we would like to
diagnosis.
get tissue diagnosis or culture, sir.
Or urine AFB culture, isn't it?
Culture, yes, sir.
Have you sent urine AFB culture?
Sir, urine TB culture that
Yes.
was written, it was negative, sir.
Urine AFB, how much time does it take to get urine AFB culture?
6 to 8 weeks, sir.
2 8 weeks.
6 to 8 weeks. And you have done this patient on is admitted and quickly within 2 days you have done sonography and everything. Will you wait for 6 weeks or no? Which type of culture is this?
This hasn't been mentioned, sir, but it will usually
No,
media,
that is
LJ
no, no,
media.
no, not I was. You tell us on based on your knowledge. No,
So it can
is
be either
there?
solid base or a liquid base media. Solid base
A
I'm
is
just
liquid base
asking you.
because
LJ.
Are you? Do you know anything? Any test which can be giving, which will give you an early result of genitourinary
The
tuberculosis?
CV net, sir, cartridge based nucleic acid amplification test, sir, which can give result within 24 to 48 hours, along with the sensitivity pattern of rifampicin and INX.
Correct.
it
So
is gene expert.
rapid cultures are known, isn't it?
Yes,
Hmm.
sir.
What are they known as? Bactec cultures.
Back to
Like
yes.
MGIT,
What is
MGIT.
MGIT?
Sir,
Mycobacterium growth
growth
indicator tubes.
indicator tube. The
Yeah,
MGIT
so
960, sir.
would you not want to send that for testing?
Yes, sir.
So ask for that, no, that I would like to send for rapid bacterial cultures from urine. How would you improve the culture sensitivity or
By
the
taking
yield of the culture? How will you improve your yield?
the culture three consecutive early morning samples, sir.
Which
Early
can
early morning samples and further, and what?
Yes.
So a patient gets up in the early morning, 6 o'clock, gives a 10 ml volume sample in the
And
small container. Is
it
that
should be
fine
around
for you?
no, sir. It should be around 30 to 50 ml of urine should be given
Yes. And why so?
because the disease is possibacillary and we have to get a maximum concentration.
Correct. Then you should have said that all these things, no? All these things, if once you say that, then the examiner knows you know your knowledge. Otherwise, all throughout till now, nowhere have you tried to demonstrate your knowledge at all. You want to show to the examiner, no, that you know the TB, you know general knowledge, you have read. So try and show that to examiner, no? So you should ask for rapid cultures, backtech cultures, ask for proper thing. And then if all these things are negative, then you go for what?
tissue
Tissue
diagnosis.
culture.
It should
Tissue
have.
culture. You did a cystoscopy, isn't it?
Yes, sir.
Why did you not ask for biopsy of bladder?
So cystoscopy was done in the past.
Would you not like to do it now?
Yes, agree.
You were given a history that the patient was catheterized.
Yes, sir.
Yes.
At the same time, the MCU showed two tight strictures.
Yes,
And
sir.
Dr. Shah said that he had to pass a glide wire to pass a catheter. Did you ask which number Foley catheter was
So we have initially
inserted?
asked in the history, sir, whether we
So which number Foley catheter was inserted?
It was.
Why am I asking this?
What is an importance? He is Dr. Gupte is saying when you are asking about the size of the catheter, what is the meaning of that?
So whether it would be
Suppose
available to
if I
luminant,
tell
we can
you
get a idea of luminant diameter of the urethra, sir.
correct. So what is acceptable? When will you
Sir,
say that this patient has no stricture or stricture which doesn't need any treatment, further treatment?
a luminant diameter of in male, a luminant diameter of more than 18 French is
No,
considered to
not
be.
at all. Not at all. If you are able to pass a 16 French catheter, this patient does not need any further treatment for that stricture. That's a rule. 16 French. Okay. Now tell me, why was the bladder biopsy not taken when you did a cystoscopy? Would you do or no? Would you take a bladder biopsy or would you not take a bladder biopsy?
If we have a strong suspicion of GUTB and all the rest, microbiological and molecular testings are coming to be negative, and we have a strong suspicion of GUTB, then we would definitely going to take a bladder biopsy.
So before doing CT scan, would you do a biopsy?
No,
Or
sir.
would
After
you-
doing after imaging,
After imaging.
yes, sir.
Why after imaging?
Sir, before imaging will also imaging will guide imaging will tell us the status of the kidney and other extra pulmonary extra to
What?
genitourinary tract or it will also guide us about the lymph node status and calcification. So we have a it gives us a one of the it fits into one of the minor criteria of GUTV, sir.
What is the? Are you not aiming to get a tissue diagnosis?
Sir, if the CT scan is showing that if one of the kidneys or any significant renal involvement with caseous necrosis or some slough, then we would like to take a biopsy
How
from that site.
on a CT scan, how will you know about caseous necrosis?
Sir, if there is a significant cortical cyst with no any uh, kidney function or less uptake with more
Does
probably
that prove caseous necrosis?
no,
Cases
sir.
would be always on histopathology only, sir.
Correct. Then CT scan is not going to tell you about caseous necrosis. CT scan will maximum tell you about functioning, non-functioning, dilatation, non-dilatation, calcification, no calcification. What further? What else?
If primarily kidney is more
No,
involved.
Brijesh, understand what Dr. Gupta is asking.
Okay.
In a normal cases, these are the findings you get. But what are extra findings you will see in CT scan in geocox?
Sir, we can get the even a smaller lesions up to 3 to 5 mm, and also though rare but involvement about the vertebra status or any psoas abscess or psoas collection. Along with that,
No,
with
you are going too haywire. This
No.
where is the question of smaller lesion here? The whole kidney is enlarged. There are multiple cystic lesions, dilatation,
Sir, if there is,
everything. Where is the question of smaller lesion?
sir, if there are classical pathochromic signs like phantom calyx or
Calyx.
moth-eaten calyx and some changes of ureteric strictures, then it would more suggest that upper tract involvement with more probably renal involvement. So it would give us more yield in the biopsy. So we would target kidney SS. So
Then
we
you will
would,
take a kidney biopsy.
no, from the pelvis, or we would do a PCN.
You
and
will
then
do a pelvic biopsy.
via
How will you
PCN,
do
sir,
a
we can
biopsy
do
from
a
the
biopsy of
pelvis?
the tissue.
Will you do a PCN in this? Will you do a PCN?
Sir, if there is a significant upper tract
Why
change,
will you not do a PCN in this? Is PCN done routinely, very left, right, and center in a GU Cox patient?
No,
no,
sir.
no, sir.
Why?
It
Why?
may lead to fistula formation, sir.
Fistula.
Correct. So you want to do biopsy from that lesion? What are the easiest ways of having a tissue diagnosis?
The
Doing
cystoscopy
a cystoscopy and doing an
and bladder
Cystoscopy
I
and
biopsy.
think
Bladder
cystoscopy
biopsy.
bladder.
and bladder biopsy, isn't it?
Yes,
Then
yes.
why are you so hesitant in doing that? Is it very dangerous to do cystoscopy biopsy?
But in case of a GUTB, sir, with a thimble, low capacity bladder, there may be increased chances of perforation. So that's why.
Perforation? Why
No,
would it perforate?
we have to do with minimal filling and gentle.
Correct. Gentle this thing. Okay. Otherwise, you will not see anything.
Yes.
So while introducing the sheath, you have to use minimal fluid.
Irrigation.
And then from what will you look for in bladder? Which
And
areas
then
will
you-
you look for?
around
Tubercles.
the ureteric,
Don't.
orifice, sir, we will look for any hyperemia or any tubercle, sir.
Okay. And what else?
So the
And
shape
any
of the orifice, your golf hole.
Correct. What are the different shapes of the orifice?
golf or volcano shape orifice can
Volcano
be
or golf.
seen.
And why do they develop like that?
Because
Sir,
of involvement of the
longitudinal
longitudinal nerves.
fiber, sir.
At which, suppose if there is a golf hole or a ureter, what stage does that indicate to you?
Late stage, sir.
Late advanced stage.
Advanced stage, correct?
Yes, sir. Yes, sir.
Which means fibrotic stage.
Yes.
Already
Yes, sir.
fibrosis has occurred. Correct?
Yes.
In which case, is your biopsy likely to be positive or negative?
Negative, son.
Negative. So biopsy, when will you be like the yield of biopsy will be highest in an early phase or late phase?
Early phase, sir.
Early.
Early phase.
Early
And
ischemic
you
phase,
see
sir.
tubercles, which
Yes.
is a most from where will you take the biopsy to get the maximum yield?
Intertrigonal area, sir. Along the mercy.
Intertrigon
From the
around
tubercle, we
periureteric.
periureteric area.
Periureteric organ.
Periureteric. Will it be a TUR biopsy or a cold cup biopsy?
Cold cups.
Cold cup.
Cold cup biopsy. Why not TUR biopsy? You will get a nice good chunk, no bleeding, nothing,
Sir,
clean
while using
biopsy.
a while doing a hemostasis, we have to use coagulation, and then it may cause ureteric asphyxia. Sir, matlab, it will close off the ureter, sir.
No, no. Why will it close ureteric organs? Take a nice TUR biopsy. Why do you want to take cold biopsy? You said no just now.
The
The biopsy.
bladder architecture of the tissue will be well maintained, sir, while taking
Okay, agreed.
cold cup
Agreed,
biopsy.
but that's not the reason. Agreed. What is the more like
Sir, because we have to do a very gentle attempt. We can't overfill the bladder for
agreed? Agreed. Still,
TUR bio.
histopathologically. See
Deep muscle
where is the disease?
in the trigonal area, sir.
In
In
the
the
no. Is it in the mucosa, lamina propria, muscle, deep muscle? Where?
Lamina.
Mucosa and lamina propria.
lamina
Mucosa.
No?
propria.
Yes.
So why do you want a TUR biopsy? In a TUR BT or a CA bladder, you want to know how deep the
Muscle
malignancy
invasion.
has gone. Therefore, you do a TUR biopsy. Here you want basically a mucosa and the lamina. That's it. You are not interested in the deep detrusor muscle. Therefore, cold muscle is sufficient. Therefore cold cup is enough. And of course, the other reason, the histopathological architecture is maintained. You have to be very gentle. The coagulation will disturb the architecture. It will be difficult for the pathologist to diagnose few. What are the pathognomonic signs the pathologist will look for?
Caseating necrosis along with giant cells and
Epithelioid giant cells.
epithelioid
Langerhans
giant.
types of giants.
Not Langerhans.
Langerhans.
Langerhans giant cells. Fine. Okay. Proceed.
Okay, okay. So I will just to your question. Question number one originally was that why you want to do CT scan? Number one. Okay, Ankit.
Yes,
So
sir.
I want you to tell me that in a what are the difference? That means what extra you will get it in CT scan compared to sonography and simple plain IVP. So what are the extra
Sir,
things you will see? Number one, listen. And number two, why you want to do CT first and then cystoscopy later? Why you want to do that? Answer me these two things.
while doing CT urography, we can stage and see the sequelae of the disease. We can get knowledge about the extra renal involvement. Like we can look other solid organ involvement, and we can get a idea about the lymph node involvement and any extra renal calcification. And we can have we can look into the functional and anatomical detail of the kidney, sir. We can get a intramural idea of the ureteric involvement.
No, start from cortex. What are the findings you will get in tuberculosis?
Sir, in the cortex, initially we get a cortical granuloma, along with followed by we can get a papillary necrosis, followed by we get a infundibular stenosis and hydrocalyx, followed by, and we get a after that the bacilli sheds off in the ureter. We get
Phantom calyx. Phantom calyx.
phantom calyx, and followed by in the later stage we get a lower calcification along with autonephrectomy and putty kidney, sir.
Very
Lower calcification.
Very good.
uh,
It is about a kidney. Then what
yes,
about
sir.
a pelvis?
So pelvis may be hiked up after
Per skin.
involve. Sir, skin sign will be there. Hike up pelvis will be there due to fibrosis. And in the intramural
PUJ.
ureter, we
PUJ
get a
obstructions.
PUJ obstruction, and in the intramural ureter, we get a calcification along with the lead pipe ureter. A corkscrew appearance will be seen. That is the alternate dilatation and stenosis of the ureter. And we can visualize the VUJ obstruction or VUJ structure. Lower ureteric structure will be better delineated. Along with coming on to the bladder, we can in the bladder we can get the we can see the calcification, trabeculation, any diverticula, and the size of the bladder, sir.
Gimbal
And
bladder.
and in the yes, sir. This
And
also.
what will happen to the posterior urethra?
Sir, it may be there may be some stenosis of the posterior.
No. Many a
It
times
will
they
be
have
dilated, sir.
incontinence. Dilated. Many a times
Dilated bladder
Dilation.
vessel.
posterior
Yes,
urethra
sir.
will be dilated. Okay, very good. So these are the findings. Now, Samit, why you want to do? See, he was asking you why not to do cystoscopy first, and Ankit said, "No, sir, I want to do CT scan first." Why you want to do CT scan first and not a cystoscopy first?
So, CT scan first will just give the idea, what as per the radiological signs that we are going to we are dealing with TB, and
No, but
definitely.
all these signs. So even if you do cystoscopy, you are going to get later on. If you do CT scan, why you want to do CT scan
But sir,
first? Then what
upper
is your
tract
answer?
involvement and see the status of the kidney, the functionality, involvement of the ureter, the status of the ureter, evidence of any stricture or changes, because there are hydrocalcicosis and there is callicial
No,
dilatation
no,
which
I
is seen.
agree. But all these things you can see later on also, na? You do cystoscopy, you take a biopsy, then you do CT scan. Any logical answer for this?
If we do cystoscopy first, then we have to wait for some time to do CT scan.
Why?
It will distort the architecture of the.
No. Suppose if you have done a CT scan first, and now if you see okay, there are bilateral
Sir,
uretic strictures,
so cystoscopy at that time, then we can do RGP also.
so many things, na?
Yes. So,
You
like if it is CT scan, if it is suspected and seen all the findings, then at the time we come to know that in the cystoscopy we have to perform RGP and look for that. And immediately, if any intervention is needed to put a
exactly.
stent or that we
Correct.
can.
So
Correct. Absolutely correct.
you understand? So Dr. Gupte was asking you that only, that why you want to do, that means you do cystoscopy, you take a biopsy, then you do CT scan and you say, oh, I have missed this uretic stricture, I should have done degestenting. Then you call the patient and then you do degestenting to save the kidney. No. So first you do CT scan, you get anatomy, functional, and you can decide for the further management, and that time you do cystoscopy and decide what else you want to do. Okay, fine, good. But you answer very well. Okay, show the CT scan.
Alright, one more thing. Hello.
Yes, sir.
Pankaj bhai, I want your
Then,
view.
yeah, Gaurang, one more thing. So
Yeah.
that once you have done CT first and then you do a CT cystoscopy, you know that you put a ureteric catheter in the left side and collect the
Urine.
left-sided pelvis urine from the renal pelvis and send that for AFB culture specifically to improve your yield of getting the positive culture from that side. So that is another one more advantage.
Pankaj bhai, now till now you're not said anything. We want your views.
No, nothing addition, but you see, before you intervene, before you do a cystoscopy, you should have the complete information about the patient. Knowing details of upper tract will be very important. You will know which side to intervene. If there are associated strictures, you could take a biopsy, and as Deepak said, we can also collect upper tract urine for AFB culture or whatever further things we want to do. So any case before intervention, collect all the information.
You got, all of you got the answer?
Yes.
Very good. Okay. Bye. Show them IBP.
Anyone is reading?
Sir, I'm
What are
showing
the
all
pri-
the images
what are the
first.
primary criteria? What are the secondary criteria?
Sir, I'm showing all the images first, and we still have
Okay,
one or two
okay,
more.
okay.
Show them all the films. Okay. Who want to try? Samit, Ankish, Brijesh, or any other student today? Today is the last day.
This is a contrast non-CT scan of abdomen and pelvis, which showing all solid liver, gallbladder, spleen seems to be normal. The right kidney, in the right kidney, there is good contrast uptake with maintenance of corticomedullary differentiation and the ureter. And there is no hydronephrosis seen in the right kidney. While on the left kidney, there is multiple cystic area with without parenchyma is seen, along with the on the there is dilated ureter seen on the left side with abrupt termination of the ureter in the abrupt termination of the lower ureter, sir. In the reconstructed film, there is and the bladder seems to be small capacity bladder with a thickened wall.
Okay, so Ankit, what are the signs you are able to see, and what are the signs you will be seeing? In this case, in this CT scan, there are many signs you are able to see. What is described in the your textbook also, correct?
Yes, sir.
So tell us.
There is hydrocalicosis. Then
So
the
multiple
lower.
hydrocalicosis, and what is that
So
sign
then,
called on the CT scan?
so there is a
Someone's foot,
Beer closet.
bare
there.
claw. See properly. Can you see it?
Yes, sir.
It
In the
appears like
upper second image.
correct. Then what else?
Sir, infundibular stenosis is seen, sir. And pelvis is not dilated and that it is hiked up, sir. Towards skin.
Cursing.
Then
And the ureter seems to be lead pipe ureter is seen, sir.
Pipe
yes,
stimulator.
very good.
And the bladder seems to be there is thimble out bladder, sir.
Yes. See, so many signs you have seen, correct?
Mm.
And there is even the calcification or the stone, whatever it is, we don't know, in the left side.
Yes,
Yes.
sir.
Okay. Show them the report.
Right kidney is normal in size, measuring 10.6 centimeter. The right distal ureter is tortuous and dilated. Rest of the proximal and mid ureter shows normal course. No evidence of focal lesion or hydronephrosis. Left kidney is small, measuring 8.9 centimeter and shows irregular outline and diffuse cortical thinning with calyect. Diffuse hypoenhancement of the parenchyma with non-excretion of contrast even on marked left perinephric and periureteric fat stranding is seen with associated with diffuse urothelial thickening as well as of the Gerota's and Zuckerkandl's fascia. Few hyperdense areas with air foci are noted within the collecting system of the left kidney, predominantly involving mid and lower pole, suggestive of residual contrast within the collecting system, secondary to recent retrograde pylography. Aorta and IVC are unremarkable, and there is no evidence of significant abdominal or pelvic lymphadenopathy. Distended small and large bowel with neutral contrast are normal. Urinary bladder is markedly contracted with Foley's bulb in situ. It shows diffuse urinary bladder wall thickening, giving a thimble bladder appearance with reflux of contrast into the bilateral distal ureters on excretory phase, suggestive of VUR. Prostate is normal. Periprostatic fat, and along with the impression, there is a bilateral atrophic adrenal with calcifications.
Fine. Samit, now these are the total findings. Now you know it. Now
Yes.
what you want to do?
Sir, based on this,
One question, wait. Why is this not xanthogranulomatosis pyelonephritis?
so because there is no pelvic stone,
Why do you need pelvic stone in XGP?
so usually a triad of nephrolithiasis, obstruction and
There
infection
is a
with
triad of stone, but not
stone.
necessarily renal pelvic stone.
Yes.
We can see a stone here. There in the fourth shadow, you can see a
Yes.
stone.
Yes, on the top film, the right hand side, the fourth one, the most right on the top.
So there is disproportionate dilatation of the calyces. There is non-dilated small renal pelvis. There is thinned out parenchyma, and there is a calculus. So all features of classical XGP. Rather, the bear paw sign that was mentioned is
Was in
classical
XCP only.
for XGP and not really for Dewcox. So here you would not call it XGP because of the associated findings of the ureter and bladder. But if you are
Okay.
looking only at kidney, this is a classical XGP. Okay. Again, you see, though they later on told us that these air pockets are because of RGP, but in the second and third image especially, you can very clearly see the air pocket. Please don't miss those things. Can you see that small air dot, black dot?
Yeah.
Yes, sir.
Yes.
Yes. So it is only because of the small non-dilated bladder, or rather a thimble bladder, and a very stiff thickened ureter that we will keep Dewcox as a first diagnosis. Otherwise, the kidney findings are classical XGP. Just a theory question coming to XGP. What are the types of XGP? चल कोई बात नहीं. Come back to the case.
Yes. Anyone? Ankit?
Remember, sir.
No problem. You can refer to your book or something.
No,
When
segmental is not the right word. The right word is focal. So diffuse or focal.
Okay, fine. So now, Samit, now what do you want to do?
Sir, based on the findings, I would explain the patient about all the findings, and then now proceed ahead with because there is even abrupt termination or cutoff in the left-sided distal ureter. So for further confirmation, I would like to have uh, do a cystoscopy, visualize the bladder, and uh, take any biopsy for suspected areas, and do a left-sided RGP, and then proceed uh, further.
Why only left-sided
What are you
RGB?
wanting to do?
So the
So
so look
I'll tell
for the
you, let's presume that RGP shows multiple strictures in the ureter. So what is your plan next?
so then
First of all, before going for any intervention, I would like to have a functional scan, sir, in the form of
Absolutely. Well
DTPA.
said. So you see, Samit, I'll again repeat. Collect all information before you intervene. Okay. Now this is a patient with nearly thin cortex. The cortical thickness is hardly 3-4 millimeters. Lower pole में शायद थोड़ा सा 5-6 millimeter है. Otherwise, it's a very thin cortex. So you do a RGP in this patient who already has a partial obstruction. This patient may land into sepsis. Okay.
yes.
So I would first get a nuclear scan done, assess the function. Now I would know how much the function is, cover the patient with appropriate antibiotics, and then proceed with cystoscopy and RGP.
Yes.
That too based on my DTP renogram or nuclear findings.
So, Samit,
Yes.
you have understood what sir is trying to tell you.
Yes. Yes. Yes.
And suppose if you have not done any functional test, now left-sided you have done RGP, it is showing hydronephrosis or maybe hydrocalyx and there are stricture. You will be tempted to do not only RGP, but what you will do is next step will be you will be doing digestion.
Thank you.
Okay. So you have
Yeah.
already done one extra procedure. Fine. Now
Yeah.
after that, you do functional test and you say that this kidney is absolutely not functioning.
Then I have to
Use of
proceed with
doing
yes.
digest.
Then that stenting was absolutely unnecessary. No?
Yes. Yes. Agreed.
So before doing, he is very clear. Before doing any intervention, gather as much as information which is useful. Any information you take it to find out whether you are changing your diagnosis, you are supporting your diagnosis, or are you improvising in your management. Then you do that particular investigation and then you go ahead with the intervention. Okay, Rahul, show them.
Mhm.
No, it's on the left side.
बताइए पढ़िए भाई जल्दी.
चलो अंकित.
So this is the DTPA scan. In the initial perfusion phase, there is uptake of contrast from the right side, but there is no uptake of contrast from the left side.
Right side.
It not contrast isotope.
Isotope,
Right.
sorry, sir. Isotope on the left side. And on the perfusion, on the filtry phase, there is a there is no radionuclide uptake is seen with the delayed excretion of contrast from the right side, sir. So, and there is reflex is also seen on the left side, sir. And,
So at least you do, hardly you can see any contrast on the left
oh
side.
no.
And can you
Yes,
see
sir.
the ureter which is on the right side?
It is there is reflex on the right side also, sir. It is There is reflux, grade 2 reflux is
So,
grade
Ankit, I
1
will
reflux
not
also.
agree with reflux diagnosis because
Yes.
to call something reflux, you should first see a full bladder.
Yeah.
I don't see isotope concentration in the bladder.
Correct.
So ब्लैडर में नहीं आया और रिफ्लक्स हो गया, ये कैसे होगा?
So there may be some dilatation, na? There may be a stricture also, lower end, right or wrong?
Yes, sir.
You see, I have one more suggestion. Like the CT scan had reported reflux. Okay. Now, reflux is a diagnosis which is done on a dynamic test. Okay. So, unless you are there and you have seen that patient has voided, and after that there is increased dilatation of the ureter, or during nuclear scan you have asked the patient to empty his bladder, and then you have seen increased uptake of isotope, increase say isotope count, only then call it reflux. Otherwise, on these static images, please don't diagnose reflux. As it is,
Absolutely correct.
diagnosing reflux at this time is not going to change your treatment. Absolutely.
Second thing, already
Okay, sir.
MCU was done. You have seen it.
Yes, sir.
So there was no reflux in that.
So in test पर reflux diagnose कीजिए ही मत unless you were there at the time of test, or you at least see a full bladder and then see sudden increase in isotope activity.
Okay. So here
Yes, sir.
also you can see that it is not totally, the isotope has not totally gone away from the right side also. And there is a
Yes.
definitely some dilated ureter. You can see it. Right?
I
Fine.
remember, sir, once in a mock exam in CMC Vellore, somebody said reflux on CT.
Mhm.
And Ganesh sir really got angry. He said, "You will fail the exam if you ever say this."
Absolutely. So
It
static
should be
images पर
only
आप
commented.
reflux
Yes, sir.
diagnose ही नहीं करोगे.
Correct, sir.
So what you have learned today, whichever test you are doing for a particular reason, only talk about that. If you are doing MCU, you are doing it for to see the urethra and also to see the
Okay.
reflux.
Okay.
Then you comment on that. You understand?
Yes, sir.
Fine. Okay. So now what you want to do? Samit, what you will like to do?
So the left-sided function is only 9 and GFR is, so it looks like a non-functional kidney, sir.
Yeah. So what you want to do, sir?
Uh,
Chalo, I am asking you. You want to do cystoscopy, left-sided RGP, want to collect the urine, and right-sided digesting, and then biopsy of the bladder, or you want to do cystoscopy, biopsy, and left-sided collection of urine if possible, or you want to do only cystoscopy and biopsy?
I would like to go for cystoscopy with
it's
RGP
good.
and with collection of the urine from the pelvis, along with right-sided digesting, sir.
Right-sided digesting.
No,
Why?
no, sorry, sir. Not
Only
right-sided. Only I will
cystoscopy,
do
collection of urine
cystoscopy
and
by of
left
urine
RBG.
and biopsy also, bladder biopsy.
Hold on, hold on. You see, collection of urine, your decision of going towards upper tract will depend on what you find on cystoscopy. Suppose on cystoscopy you find multiple tubercles where you can take biopsy. Why do you want to take urine from upper tract? How is it going to change anything there? And with probable strictures, it is possible that you will not be able to take urine from upper tract. Okay. Why do you want to do cystoscopy per se? Now you have a non-functioning kidney, probably geococs. Why not directly do nephrectomy?
Since the
But
patient is having no complaint of non-functioning kidney, it is basically a knock off kidney, There is no fever.
Hmm.
There is no sequelae of non-functioning kidney. So we will not touch that kidney at this point of time, sir.
When would you call a autonephrectomized kidney? And will you not touch that kidney?
So basically, you see, what I'm trying to ask is, how is cystoscopy going to help here?
Cystoscopy
Sir,
will
it will
get
help.
to know about the tissue diagnosis, and then we need to start AKT or not for that, because we need for coverage for the other kidney also over period, because it's not a isolated involvement of only the left kidney, it's the entire system.
No.
Perfect. So the question is not about the left kidney. The question is about the better functioning kidney.
Correct.
And you would want to start AKT before you really say do any surgical intervention in this patient. AKT to the period of minimum 3 weeks or longer. Okay, there is, as you rightly said, Ankit, there is no hurry of doing nephrectomy here because patient is asymptomatic. But I did not agree with your comment that because there are no sequelae of non-functioning kidney, you would not operate. There will be situations where patient is absolutely asymptomatic for non-functioning PU junction obstruction kidney, and you may still take a decision to remove that kidney.
Okay, I have got one suggestion. Can you see that IVP again? Rahul, just show them the last film of IVP. No, that. Yes. Okay, Ankit. Now just see right hand side. Are you happy on the right hand side?
No, sir.
Tell me about the calyx. Can you see the lower calyx? Can you see the upper calyx? Can you see that infundibulum is narrow? Can you see on the right?
Yes, sir.
There is a hydrocalyx lower down. Maybe an abscess formation, maybe there or some. And see the ureter. You think that ureter is good?
No, sir.
No, sir.
There is some.
Kings and tortuosities.
So now if you're going to start anti-cox treatment on this patient, I don't know. During our time, we were taught that it is always better to put DJ stent.
Degenerate.
Otherwise, the chances of strictures are very high. And now this patient is already on a corticosteroid. So there is no need to start like, otherwise we start even steroids. Correct?
Yes, sir.
So just tell me, are you very happy with this ureter?
No, sir. No, sir.
So I will tell you the cystoscopy findings. It was a
So,
small capacity.
Just to complete here, you see,
Yeah.
the dilated lower ureter could very well be because of the very small capacity bladder.
Yeah.
Yes, I agree with your point that there is a thought of placing stent before starting AKT. But one more option could be you start AKT and regularly follow up the patient by a sonography to see for any increasing hydronephrosis, and only then place a stent. And देखिए static again ये CT पर I don't know whether we should really call it as stricture, but yes, it's not looking a normal ureter. I take your point. ठीक है sir, I agree.
Now, this is all Maheshwari ji, all retrospectively, because when we did
Yes.
cystoscopy, we were expecting that left side will not be seen ureter, but were not able to find the right uretic orifice. And left we could. So that was our cystoscopy findings. See the left side, this is the RGP. So, Ankit, can you comment on this? What are the different things you are seeing now in RGP?
There is hydrocalyx along with the infundibular stenosis is seen, and there is fuzziness of the upper calyx, sir. With the yes, sir. And the ureter is dilated and irregularly shaped, sir.
Yes. Moth-eaten appearance of the calyx is
Yes,
also
sir.
seen.
Yes.
Correct? And something
sir.
like as a,
देखिए
Golf or not
का जब भी केस हो ये कुछ वर्ड्स यूज कर लेना चाहिए लाइक माउथ अपीयरेंस, खासकर जब है मींस लोअर कैलिक्स अपर कैलिक्स में That's the classical mouth-eaten appearance. So, non-existent or a very, very contracted renal pelvis, long, narrow infundibuli, mouth-eaten appearance in the calyces, few dilated spaces, which probably represents the cavities. So, a classical picture of classical retrograde pyelogram of a GUTB. अंकित मैं कहने वाला था फैंटम कैलिक्स से ये फैंटम अंकित हो गया है अंकित दिखाई नहीं दे रहा है
Actually, sir, what patients की call आ रही थी sir.
No, it's a good thing. So, see, in this case, you have seen everything. Now, I will tell you what this patient has got. Okay, I will summarize and I will tell you, ask you what you want to do. So, what we saw was that this patient had a stricture to start with, small capacity bladder, left-sided non-functioning kidney, right-sided we cannot find ureteric orifice. So, we have not done anything, and probably this proves that the left ureter is also affected. Kidney is also to some extent affected. So now in this case, plus patient had adrenal tuberculosis, patient has not completed the treatment, and patient had an adrenal crisis. He is already on a steroid. Now tell me step by step, how will you manage?
We will start based on the history and based on the above imaging findings. We will make a diagnosis of. We will counsel the patient and inform him that we are suspecting a genitourinary tuberculosis, and we will put him on category 1 AKT, sir.
So if you want to put AKT, you don't want to do digestion.
Sir, sir, in our institute as a protocol, sir, before starting AKT, we usually do a digesting, sir.
But in this case, digesting is not possible. And
no.
Dr. Maheshwari said that antigrade, if you do, sorry, Dr. Gupte, there are chances that you may have
Fistula.
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 So now what you will do?
Sir, since we are starting AKT, sir, simultaneously we can put a PCN, and we will try and we will go for antigrade stenting if possible, sir.
Pankaj bhai, bolo.
Is the kidney obstructed at this time?
No, sir.
No. What is the hurry of placing PCN?
So we can just start AKT and observe on sonography.
Yeah,
absolutely.
Very good. Second thing is you can repeat cystoscopy after active phase is over. For that is 1.5 months. There are very good chances that it may have improved and you'll be able to see the ureteric orifice and you can do the digestenting. Fine. So now this is step number 1. गीते सर आप किधर थे?
सर मैं इधर ही हूँ, सुन रहा हूँ.
नहीं, मैं आपको बहुत ढूंढा, आप मेरे को मिले नहीं.
अर्ली फेज में थोड़ा सा ज्वाइन करने को लेट हो गया एक्चुअली. एक मीटिंग में स्टक हो गया था, सॉरी.
सर तो आपको पूरा केस तो अभी मालूम है ना?
नहीं, अभी जस्ट 10-15 मिनट, लेकिन अंदाजा है सर. व्हाइल डिसाइडिंग द ट्रीटमेंट इन सच टाइप ऑफ पेशेंट्स, 3-4 important point one has to take into consideration, like function of the kidney, amount of hydronephrosis, amount of hydroureter, then size of the bladder. मुझे स्टेंट करना नहीं करना ये सब चीज़ों के लिए बहुत इम्पोर्टेंट है. Then function of the kidney I have already told. If that kidney particularly is functioning and if size is very small, and if it is, in spite of having a hydroureter nephrosis, if you place the stent, it will worsen the thing. Correct? Like stent symptoms are very high and patient will not tolerate the stent. Number 1. If the hydronephrosis and hydroureter is less, mild, and if the capacity of the bladder is adequate, it's not like a thimble bladder, then one can wait नेसेसिटी नहीं है कि स्टेंट डाल के ही इमीडिएटली करना चाहिए. एंटी ट्यूबरकुलर ट्रीटमेंट शुरू करो, पीरियोडिक मॉनिटरिंग करो, वर्सनिंग अगर हो रही है तो स्टेंट करो. दैट इज अनदर सिचुएशन. सो ऐसे तीसरा है कि सब कुछ ऑलरेडी सीवियर हाइड्रोनेफ्रोसिस, थिम्बल ब्लैडर, स्टेंट स्टेंट डाला तो प्रॉब्लम शुरू हो जाएगा. लेकिन किडनी एक ही फंक्शनिंग है. डेफिनेटली हियर देयर इज रोल ऑफ पेशेंट, डाइवर्जन इज नेसेसरी. तो ये 4-5 पॉइंट ध्यान में रखते हुए ही एग्जाम में आंसर देना है. ब्लाइंडली अपन कुछ भी सोच के बोलना नहीं. वो क्या ये पेशेंट में क्या है और वो ये एग्जामिनर क्यों पूछ रहा है, ये पहले सोचना है.
Yeah, that's an extremely important point that in patients with small capacity bladder, don't jump to placing stents. Patients will be very, very unhappy. And even maintaining that stent becomes very difficult.
Completely agreed, sir.
Okay. So Ankit,
Yes, sir.
though we have agreed that we'll do cystoscopy, biopsy if required. If required, DJ stenting, start anticox treatment. बराबर है?
Yes, sir.
Now you have started, patient has responded. Now next what you want to do?
Sir, after 4 to 6 weeks of complete starting AKT, we will reassess the patient in imaging, and then we, according to the findings, we will proceed, sir.
But what we will do?
Sir, since the patient is having low capacity bladder, and if the patient is having the bothersome storage symptoms, and the creatinine is in normal range, we can plan for give an option for augmentation cystoplasty.
Samit, you agree with him?
No, sir. We will observe, and after 4 to 6 weeks, so we'll have to assess after removing the catheter, because the patient is on catheter only, so we won't be able to assess how much storage symptoms is having or not. So after 4 to 6 weeks, we can plan for catheter removal, do a imaging, and assess and then decide.
No, so tell me why this patient was going into retention. His prostate is small. He's young, maybe 50 years. His stricture was there, but they were dilated and they had already put the catheter. Why he was going into retention?
Because of the small capacity.
Ankit?
Initially, there was stricture in the proximal penile urethra and bulbar urethra. And on the initial attempt for catheterization, it was done under guide wire guidance. And he might be having stricture urethra, sir. We have to assess for the stricture part also. Of catheter removal, we have to do. Although the urethral involvement in TB is rare, but this seems to have in this patient seems to have involved the urethra also.
No, but I will tell you, I don't know, Pankaj bhai, you also must have seen in small capacity bladder, even there is no obstruction, either patient has got dribbling or patient cannot pass urine. Many times they go into retention. One of the reason is because of compliant, means the bladder, it has that means the contractility decreases.
Hmm.
So that is one of the reason they keep on going into retention. Even though small capacity bladder. And many times I have seen that when we do cystoscopy, it is 100 to 150 cc. But when they go into retention and we put the catheter, it is much, much more, like 250, 300 cc retention. Gite sir, कुछ explanation about this?
सर, स्मॉल कैपेसिटी ब्लैडर उसमें बहुत सारी चीजें है कि वो सिस्टोस्कोपी ही करना ही बहुत बड़ा डिफिकल्ट काम है. जैसा भी तुम अंदर गए कि पूरा रेड हो जाता है.
Correct.
Expansibility of that bladder is very less. आप जो बोल रहे हैं मैं एग्री करता हूं कि सच ब्लैडर्स आर यूजुअली प्रेजेंट विथ स्टोरेज सिम्टम्स, सिवियर स्टोरेज सिम्टम्स, not only storage. It is urgency, urge incontinence, and dribbling is majority time is always there. Stricture urethra associated, yes, one has to rule out the stricture urethra in tuberculosis. It in spite of it, rare भी अगर रहा तो rule out करना necessity है. कैथेटर स्टेंट ऐसे सिचुएशन में बड़ा डिफिकल्ट बैलेंस डिसीजन लेना पड़ेगा. डिजेस्टेंट कितने ml से कम इसमें करना नहीं करना चाहिए, ये कोई पूछा है अपना उसमें चार्ट में. तो 2024-25 के एक दो आर्टिकल है जिसमें 50 ml से अगर कम है तो उसमें डिजेस्टेंट नहीं करना चाहिए. 50 to 100 का रेंज दिया है. दूसरा अपना जो फिजिक्स है कि उस डिजेस्टेंट का एटलीस्ट वो जो यू कॉइल है, लोअर कॉइल, वो फ्रीली ब्लैडर में रहना चाहिए, उतना तो कैपेसिटी रहना चाहिए. ये शायद ऐसा किधर नहीं दिया है, लेकिन ये जस्ट मेरा फिजिक्स मुझे लगता है कि वो कॉइल थोड़ा फ्रीली इधर उधर घूमने जैसा, तो एटलीस्ट 100 ml तो कैपेसिटी रहा तो ही वो स्टेंट का जो लोअर एंड है वो इरिटेट कम करेगा. अगर बहुत ही छोटा 100 ml से भी कम है तो इरिटेशन ऑलरेडी छोटा कैपेसिटी, ऑलवेज स्मॉल कैपेसिटी ब्लैडर और हाई प्रेशर ब्लैडर्स, बिकॉज यूजुअली वो इसकी वजह से हाइड्रोनेफ्रोसिस हो जाता है. इंस्पाइट ऑफ रिफ्लक्स होने के बजाय हाइड्रोनेफ्रोसिस हो जाता है, क्योंकि वो प्रेशर की वजह से वीयू जंक्शन पे प्रेशर होता है और बंद हो जाता है. तो ऐसे सिचुएशन में बहुत ही सोच समझ के डिसीजन लेना पड़ेगा. ऑगमेंटेशन अगर कर रहे हो तो ट्यूबरकुलोसिस, इंटेस्टाइनल ट्यूबरकुलोसिस है कि नहीं, और रूल आउट करना, सीरम क्रिएटिनिन कितना है, सेगमेंट कौन सा यूज करना है, ये बहुत सारी चीजें उसके साथ भी आ जाती है. सर शायद ये हो गए क्या?
पता नहीं.
Samit, I'm sorry. You will like to do nephrectomy first or augmentation first? Number one. And you'll do only nephrectomy or you'll do nephrouretectomy?
So first nephroureterectomy, then plan for augmentation, sir.
Brijesh, what do you want to do?
Sir, I would like to do nephrouretectomy, then would like to give the bladder some rest and assess the bladder with video urodynamics or urodynamics, see the compliance, and then most probably plan with augmentation cystoplasty.
उसमें देखो ये फिजिक्स है, क्या इंपॉर्टेंट है बॉडी में, तो बच्चे वाली जो थोड़ी बहुत फंक्शनिंग किडनी है अपोजिट साइड की, वो मेरे लिए ज्यादा इंपॉर्टेंट है. जो नेफ्रेक्टोमी कर रहे हो तो करने वाले, वो तो खत्म हो गया उसका कार्यक्रम. उसमें अगर कॉम्प्लिकेशन के साथ आ रहे हैं तो यस, वी हैव टू गो अहेड एंड फेस द कॉम्प्लिकेशन, ट्रीट द कॉम्प्लिकेशन. वो अगर नॉन फंक्शनिंग है और चुपचाप बैठ साइलेंट है, तो मेरा एम क्या है कि अपोजिट किडनी कैसे सिक्योर हो जाना चाहिए. अगर नीचे लो कैपेसिटी ब्लैडर है तो दैट विल बी डेफिनेटली हैव सम रिस्क टू दैट अनदर किडनी आल्सो. करेक्ट है. तो वो किडनी कैसे बचेगी वो देखना पड़ेगा. छोटे कैपेसिटी का ब्लैडर है तो उसको ऑगमेंटेशन पहले करना चाहिए, ऐसा मुझे लगता है. प्रोबेबली बाकी सब लोग उसके ऊपर लाइट डाल सकते हैं. असिम्टोमेटिक नॉन फंक्शनिंग किडनी में भी हाइड्रोनेफ्रोटिक निकालना जरूरी है, लेकिन अर्जेंसी नहीं है. और अपोजिट किडनी को हाइड्रोनेफ्रोसिस है, वेरी लो कैपेसिटी ब्लैडर है, क्रिएटिनिन बढ़ रहा है, तो उसको मुझे बचाना पहला जरूर मेरा काम है, तो उसको पहले मैं बचाऊंगा.
So Ankit, can you do nephrectomy and augmentation together?
सर इसमें दो चार पॉइंट है. कोई बोलेगा कि भाई नेफ्रेक यूरोट्रेक्टोमी और ब्लैडर पे निकाल दो, अपोजिट साइड का यूरोट्रोस्टोमी कर दो, थोड़ा मेजर हो जाएगा अगर पेशेंट फिट है तो, लेकिन एक बार का प्रॉब्लम ही सॉल्व हो जाएगा. इतना 20-25 ml का अगर ब्लैडर है या 30 ml का थिम्बल ब्लैडर है, तो उसको कौन सा ऑगमेंटेशन करेंगे? उसको तुमको न्यू ब्लैडर करना पड़ेगा। न्यू ब्लैडर के बहुत सारे कॉम्प्लिकेशन है। एज, पेशेंट का एज क्या है, क्रिएटिनिन कितना है, टॉलरेंस कितना है, फिटनेस कितना है, बहुत सारे पॉइंट को ध्यान में रखना पड़ेगा। उसके हिसाब से डिसीजन लेना पड़ेगा। यस, इट कैन बी डन। नेफ्रोरेक्टोमी एक्स प्लस ऑगमेंटेशन भी कर सकते हैं, कोई उसमें दो राय नहीं है, लेकिन वो पेशेंट टॉलरेट करता है नहीं करता है, इसके ऊपर बहुत सारी चीजें डिपेंड है। फिर अपोजिट साइड के किडनी का क्या सिचुएशन है, तो करने का है सर, तो सिचुएशन के हिसाब से नेफ्रोरेक्टोमी विथ सिस्टेक्टोमी, नेफ्रोरेक्टोमी विथ ऑगमेंटेशन सिस्टोप्लास्टी, ओनली नेफ्रोरेक्टोमी एंड लैट्रॉन सिस्टोप्लास्टी, या पर पहले सिस्टोप्लास्टी एंड बाद में लैट्रॉन, ये सब परम्यूटेशन कॉम्बिनेशन आपके पास है, और वो बहुत कॉशियसली कंडीशन के हिसाब से यूज करना है।
So,
Okay.
Dr. Gite, that was a very interesting point of augmentation first to save opposite kidney. Means really I had not thought of it. मैं जस्ट थोड़ा समराइज करता हूँ, आप मुझे करेक्ट कीजिए इफ आई एम नॉट राइट, इफ आई एम डूइंग सम एरर. So if the bladder capacity is less than 30 ml, we go for neo bladder. If bladder capacity is more than 50 ml but small bladder capacity, then augmentation. If there is CKD, then obviously there is no role for augmentation. Then you think about cystectomy with ureterostomy or cystectomy with a ileal conduit.
Correct.
Would this be the right thinking?
Correct, sir.
And in this
But-
patient, because
But my
my
question is, if it is a very small capacity bladder and if it is a CKD patient, just do ureterostomy. Why
yes,
to do also?
सर
नहीं
नहीं,
सर,
उसमें
cystectomy
सर
करना पड़ेगा सर, क्योंकि we
करना
can't give a defunctionized bladder.
करना पड़ेगा।
Okay.
ऑब्स्ट्रक्टेड, ये देखो, यानी ऑब्स्ट्रक्टेड हाइड्रोनेफ्रोटिक किडनी, ऑब्स्ट्रक्टेड हाइड्रोनेफ्रोटिक नॉन फंक्शनिंग किडनी शुड बी रिमूव्ड।
Yeah, what if okay.
दिस इज बॉटम लाइन। अगर वो ऑब्स्ट्रक्टेड है तो वो किडनी को निकालना पड़ेगा। और ब्लैडर अगर सच में बहुत ही छोटा है, उसको तुम कुछ कर नहीं सकते हो, तो तुम न्यू ब्लैडर करो या फिर ब्लैडर निकाल दो, बाहर यूरोट्रोस्टॉमी कर दो, लाइफ लॉन्ग प्रॉब्लम सॉल्व हो जाएगा। क्योंकि न्यू ब्लैडर के भी बहुत सारे कॉम्प्लिकेशंस, मैनेज करना न्यू ब्लैडर इतना आसान नहीं।
So from your point of view, you should, I would feel exam mein, if you come in a situation where there is a very small capacity bladder with elevated creatinine, saying cystectomy and ureterostomy would be a good idea, and let the examiner lead you towards neobladder rather than you talking of neobladder. Because if you talk of neobladder, then you get grilled more about neobladder.
करेक्ट सर, मुझे तो वही लगता है। तो एक्चुअली जियो ट्यूबरकुलोसिस का केस बहुत बार एग्जाम में रहता ही है, मेजोरिटी प्लेसेस पे, इंडिया कंसिडर करके। तो इसमें सब चीजें थोरोली, सिचुएशंस को क्या आंसर देना है और उसको कैसा डिफेंड करना है, वो तुमको पता रहना चाहिए।
Acha, what are the different drugs used for the management? And okay. Ankit, before
Yes.
that, when you do the surgery, what precaution you will take in this patient? Huh?
So first of all, we would like to get a confirmation whether he has responded to the induction therapy or not. Before contemplating any surgery, we would like to have a culture sterile, GUTB culture, मतलब CB net or gene expert should be sterile, and patient should have gained weight adequately. Patient should have responded. Patient symptomology should have been improved. And then we will plan for, since creatinine is normal, we after ruling out any bowel pathology, bowel tuberculosis, we will plan for ileal cystoplasty, sir.
Ankit, my question is in this patient. These all things are common for everyone. In this patient, he has got some other problem.
Sir,
Adrenal
patient
TB,
is having
adrenal
adrenal
TB,
crisis
sir.
also, sir. Patient is
So
having
he's on
adrenal
Visalon
crisis.
and fludrocortisone.
Patient is having adrenal crisis, so we will take a consultation of the endocrine team also regarding his adrenal how to manage the adrenal crisis during intra-op and post-op period, sir. And we would like to give him stress dose of hydrocortisone during the intra-op period, sir. In the pre-op period, before going to surgery, sir.
Very good. And what about the anti-cox treatment? Because he has failed to take the treatment, he may be resistant, he may be multi-drug resistant. So whose advice you will take?
The pulmonary team, ID team or pulmonary medication.
Yes. So please see, this is what I want. In this patient, these two things are very important. And whoever will see, first two patients or two students may not elaborate. You understand? Or the first will say and second, third, fourth will not say. Then examiner will feel see they have missed something. This is very important, these 2 points. So in a particular patient, just remember, don't go just what is given in theory. In this patient, what is needed? That is most important. Very good. So MDR, you will take infectious disease or pulmonologist advice and give accordingly. Very good.
So,
Pankaj bhai, what else?
I partly did not agree with one sentence that you used, that you would document sterile culture. I don't think that is needed. Okay. And I don't think that is really possible in every patient. Because to document sterile culture means you will further need to wait for 2 to 3 weeks to get the back temperature.
Sir, either culture should be sterile or patient symptomology or patient
That part
general
is
health.
okay. But you were very clear about documenting sterile culture. I don't think that's needed.
No, before starting anti-tuberculosis treatment, what is your purpose of making the urine culture sterile?
No. Doctor साहब वो ये कह रहे थे कि before doing
Surgery.
nephrectomy, he wants to get a sterile culture.
Before what?
Before nephrectomy.
Surgery.
Before nephrectomy, urine culture sterile.
Means AFB urine culture sterile. I don't think that is possible.
सर देखो, अभी इसके एक बार ट्यूबरकुलोसिस अगर हो गया ना, तो उसको बॉडी से कोई नहीं निकल सकता. वो सिर्फ एक लेवल कम हो जाता है. तुम्हारा इम्यूनोलॉजिकल पावर अगर कम हो गया, इट विल अगेन रिसर्च. ट्यूबरकुलोसिस क्योर मतलब क्या होता है कि इट विल the bacteria, tuberculous bacteria are always there inside the body, but in insignificant number. और ऐसे पेशेंट को इम्यूनोलॉजिकल प्रॉब्लम, HIV, एड्स, ये सब बहुत सारे प्रॉब्लम साथ में रहते हैं. तो ट्यूबरकुलोसिस का कल्चर स्टराइल करके फिर तुम ये करते बैठेंगे, नेफ्रेक्टोमी करेंगे, तो समझो कल्चर स्टराइल नहीं होता. फिर क्या करेंगे? नहीं करेंगे. एक्टिव स्टेज में टीबी रहना नहीं चाहिए. उसका जो फर्स्ट 2 महीने का जो ये है, क्या बोलते हैं उसको, हाँ, कोर्स, वो उतना होना चाहिए.
वो करने के बाद में यू कैन गो अहेड.
यस. और कॉम्प्लिकेशन अगर है तो वो भी नहीं जरूरी है. कॉम्प्लिकेशन है तो करना पड़ेगा, जैसा है वैसे.
You see, more than 90% bacterial count goes down by 3 weeks of intensive AKT. So anytime after 6 to 8 weeks, you can plan surgery if patient's overall condition is good or improving.
किसी ने पूछा है कि हाउ विल पल्मोनोलॉजिस्ट असेस द इंटेंसिव फेज में, समथिंग लाइक दैट.
Let's leave it to the pulmonologist.
Yeah.
हाँ, नहीं, बेसिकली क्या है कि देखो, वो उसका एक सिंपल आंसर है कि सिम्टोमेटिक है और असिम्टोमेटिक नहीं है. क्लिनिकल सिम्टोमेटोलॉजी अगर डिसअपियर हो गई तो समझ जाओ कि तुम्हारा ये ट्रीटमेंट अच्छा काम कर रहा है. और ये भी यूरिन फॉर ये भी निगेटिव, तो उसके बाद में जो कल्चर है वो जिन कल्चर वो निगेटिव, लेकिन वो होना ही चाहिए और उसके सिवा मैं कुछ करूंगा ही नहीं, तो दैट विल नॉट बी करेक्ट.
See, especially in this patient, you don't expect his symptoms to go down. Means the pus pockets in his left kidney are unlikely to completely resolve. The bladder is very unlikely to increase its capacity. So in this patient, I would take decision based on changes in his hemogram parameters, whether he's received adequate AKT. And if all those things are there, once patient is fit for the procedure, you proceed further.
Sir, actually, I have read in one of the tuberculosis textbook, one of these criteria should be fulfilled before taking for surgery. Either patient general health should improve, or patient symptomatology should have improved, or patient culture should have been sterilized. If either of these criteria are been fulfilled, then you can plan for surgical management.
If you use the same sentence before, there will not be any discussion.
Yes.
Samjha, Ankit?
Yes, sir.
You have twisted you said that these are the 4 things which are required.
No, actually, I conveyed wrongly, sir. I wanted to say this.
Ankit,
No issue.
what I tell
लेकिन
my students always that practical exam is also a test of your language.
correct.
भाई आपके दिमाग में क्या है ये सिर्फ आपको पता है, मुझे वो उतना ही समझ में आएगा जितना आप मुझे कन्वे कर रहे हो. अगर आप
Agreed.
ठीक से कन्वे नहीं कर रहे हो तो मैं आपकी बात गलत ही समझूंगा ना, मुझे क्या पता आप क्या सोच रहे हो.
Therefore, these classes.
Therefore these classes.
They are doing amazing, but sir, both all these boys are
Fantastic.
and great discussion. Thanks to all the teachers.
I'm telling you, I want these people to get gold medal. Huh?
Really, sir.
Good. Very good.
सर वो आपके हाथ में दे दो.
If I am their examiner, I will give them.
Certainly, certainly.
Good. So any other questions? Because today is the last day and we have almost finished all. And after their exam, we will have some practical things and mock exam at the end of the October. The final date we will give you. Because even MCH is in the end of November. So we'll have 1 month before MCH and 2 or 3 weeks after the DNB theory exam.
Good luck. Do well, all of you.
Yes.
From all of us.
Thank you.
Best luck to everybody who is appearing for the exam.
Thank you, sir.
Thank you, sir.
Okay. Rahul, you have to close for everyone, huh? You are the host.
Yes, sir.
Okay.
Good
Pankaj
night,
bhai,
Gite sir,
Thank you,
Gaurang sir,
everyone.
Pankaj sir.
Thank you very much.
Thank you, sir.
Thank you, sir.
Good night, sir. Gite sir.
Good night. Good night.
Right.